I'll be telling you a little bit about the waterworks and what happens in MS. It's obviously an area of concern, and I am proud to report that there's a lot that can be done about this. And I'll be telling you about why, what happens to the waterworks in MS, and actually what can be done about it. So really, in health, if you think about it, your urinary bladder has essentially two roles. Essentially, it stores urine for some time, and then at appropriate times, socially appropriate times and places, the bladder empties itself and the bladder becomes empty. And if you think about it, in health, you would spend nearly 98% of your lifetime in the storage phase, the bladder allowing it to be filled. So this allows you to sort of sit through a meeting like this. It allows you to go to the high street. It allows you to do all sorts of bits and bobs without having to be worried about the bladder. Now what happens is in health is that the brain sends signals down through the spinal cord and inhibits the bladder muscle. And that's what allows the bladder to fill that for that period of time. Now, if there is a plaque we saw some plaques earlier on in the spinal cord or in the brain, what happens is those signals don't reach the bladder the way they should. The bladder doesn't hold, and the bladder starts getting a life of its own. It starts misbehaving. And in a way, what happens is the bladder now gets a life of its own. And even when the bladder isn't really particularly full, or in health what you'd expect the bladder to be actually filling up, the bladder doesn't. And you find problems from this bladder that can become a concern. In fact, amongst the top 5 problems, the bladder does fare. And in a survey of more than 2,000 people with MS, nearly 90% of people actually did report problems with the bladder. So it is a common problem. And in nearly 70% of those people, it was ranked as being moderate or high on the list of problems that needed sorting out. Now, if we look at what happens to the waterworks in MS, so if we look at what happens with time, I mean, each study has its own sort of prevalence figure of how much the bladder is affected. But generally speaking, 90% of individuals who would have bladder symptoms if their MS is more than 10 years in duration. And on the average, the first symptoms are usually within 6 years of the MS. However, what's important to remember is that 1 in 10 individuals who have a fresh diagnosis of MS would already have bladder problems. And hence it's so important that sitting on one side of the table, the health professional, the nurse, the doctor, the therapist asks about the bladder during that initial visit. But on the other side of the table, even if it's not asked, a person with MS should volunteer if there are problems with the bladder. Number 1, because it's important that it's noted, but number 2 is that there are sort of therapeutic strategies that help with managing those bladder problems. And what's known is that in general, that bladder problems are related to the duration of MS, but also with problems in the legs, so with leg weakness and spasms of the legs, which means that if you have a very low level of disability, quite mild, and completely independent, and have quite severe sort of overactive bladder symptoms, it might possibly mean that the bladder troubles might be unrelated to the MS. But that, of course, requires a proper evaluation. So what happens during an assessment for the bladder? So, of course, a few questions are asked, which I'll be going to. We sometimes will ask about a diary to be kept, so this is what's called a bladder diary. So you take home a diary, and then for 3 days and 3 nights, or maybe 5 days and 5 nights, depending on what we're looking for, we'd ask the person to sort of note at what times they go to the toilet to pass urine. If we're lucky, if you have a measuring jar, we ask you to sort of measure the volumes. We ask you to note what time you go to bed at night, what time you wake up, so it tells us what happens in the daytime, what happens in the night, and we also ask to mark about incontinence. It gives us sort of a real-time assessment of what happens, because when in clinic, say your nurse or doctor asks you for the bladder, you sort of really have to sort of think, oh, what's actually happening? And often it can be either underestimated or overestimated. So a real-time assessment with a diary is a simple, non-invasive tool that helps considerably and getting a proper assessment of how bad the bladder is. Now, importantly, we do want to test the urine for an infection, and I'll be having a slide later on about UTIs, urinary tract infections. And essentially what we rely upon is a urine dipstick. However, if the urine dipsticks are abnormal, you might not be able to conclude that it is an infection. So if there is a suspicion from the urine dipstick, you would want to have the urine sample sent off to the lab to confirm. However, if the dipstick is negative, if that means if the urine is clear, then you're pretty certain that it's unlikely that that you're having a urinary tract infection. The fourth point that we would want to look at is to see if the bladder is emptying after urination, which is extremely, extremely important. Now, unlike symptoms of urgency and frequency and incontinence, which are quite obvious, they're quite embarrassing, and most often your doctor or nurse will ask, or you would volunteer the history, bladder emptying isn't something we think about. I mean, if you have a poorish stream, if you don't pee as well as you should, or, it's not as strong, or it's stop and start, it's something that comes on with time, and it's not apparent unless it suddenly happens. So say if you go into retention and you can't pass urine at all, then it becomes obvious. Otherwise not. So it's important the bladder does empty, and it's something that might be missed from a history or from a bladder diary, and hence the importance of a bladder scan or perhaps an in-out catheterization that'll tell you if the bladder is emptying or not. Now, number 5 is a test called urodynamics. It's a test that we don't perform in every person that comes our side. There are certain indications where we would want to do this test. It's a test that involves putting a tube called a catheter into the bladder. Not the most delightful of tests to have, but a very important test because it does give us information about the bladder. I won't be going further into this test because it's probably not a test for everyone. And then, of course, the 6th point talk about treatments. So I go through all of these. Now, this is a picture of the bladder, and essentially, there are 2 sets of symptoms that we ask about. And the first set of symptoms of urinary urgency, which is that compelling desire to need to go to the toilet, frequent visits to the toilet, so we might ask you how often you go in the day and how often you get up at night, which is called nocturia, and of course incontinence. Now, we tend to assume that incontinence is always associated with urgency, so the common scenario is that you're urgent and desperate, and you're looking for that toilet, and then perhaps an episode of incontinence occurs. However, incontinence can occur for other reasons as well. For example, if you're a lady who's had babies, for example, it could be a stress incontinence from a weak pelvic floor, which of course the treatment is entirely different. So a few questions would help us to sort of understand the cause for the incontinence. We also ask about what we call voiding symptoms. So this is sort of hesitancy, sort of having to wait to get the stream to start, having to sort of strain with your tummy muscles to get the flow going, perhaps an interrupted stream that tends to stop and start, and sometimes what we call double voiding, where you've passed urine, you feel that everything is fine, might even leave the toilet, but in minutes having to go back and pass a significant quantity again. So these are essentially the 2 sort of sets of symptoms that we ask in a uroneurology clinic. Now, measuring about whether the bladder can empty is the term that we use is the post-void residual, or the PVR, which is something that if anyone in this room has bladder problems, it's a term that you might hear. And what it is passing urine and then having a bladder scan, an ultrasound, essentially. It's a handheld ultrasound, as you can see, so it's something that's available in most sort of continence clinics. And essentially what you measure is how much of urine is left behind. This can also be sort of measured by an in-out catheterization, so putting in a catheter after having passed urine and seeing how much is left behind. So there are 2 ways of actually measuring this. A critical value to decide about what sort of treatment that's required. Now, if the person is retaining urine, the question, of course, is what to do about it. Now, unlike for urgency incontinence, for which there are many therapeutic options that are available, when it comes to urinary retention or incomplete bladder emptying, the options are limited. And what we do sort of talk about is sort of using catheters. There are a variety of catheters that are out there on the market. And you have sort of, sometimes you have catheters that have sort of, that have bags attached. You can have catheters that don't have bags attached. You have very small sort of catheters like these. I've not met anyone who's looked forward to using a catheter. However, I have met many, many people who have come back after having met my nurses and have started catheterization and said it's not a big deal. And so it isn't probably natural to introduce a tube into the bladder to empty the bladder, but it does help. It is actually quite useful because when it gets the urine out, but also it does open up newer treatment options such as pills for the bladder or even Botox if you are retaining urine. And there's a large variety of catheters out there on the market, which is good because as a user or someone who needs catheters, there's quite a few that one can select from. And it can be a daunting task initially, but that's the job of the continence nurse. And so it's essential to have a good continence nurse, one who understands the bladder, but also a nurse who understands what MS is and what happens in MS. Many of the catheter companies do come out with sort of booklets like these, which are actually quite descriptive, very simple to understand, and they have sort of pictures and figures that makes it very clear what's going on. And so a little bit of awareness of what catheters there is by reading some of these booklets or speaking to a nurse goes a long way in sort of exploring this option. And, of course, there are issues specific to MS where catheterization can be a problem. For example, there are spasms and the legs sort of adduct and cross one another. It becomes an issue, especially in a woman, to catheterize, in which case one can use sort of like a cushion like this that keeps the legs apart. Now, often, especially once again in a woman, it's finding the urethra which is a problem, and having a mirror can go a big way in addressing that problem. This is just showing that these are the catheters with bags attached, which makes it a sort of a self-contained unit. And of course, the companies sort of advertise their catheters as being very small. Would you agree that this is the size of a lipstick bulb? I don't use lipsticks, I can't say. But I guess it is. And this is sort of the adverts that come out. So it can be quite discreet. It's something that you can fit into your handbag. But it does help immensely with approaching the options for the bladder. Now, when we talk about treatments for the urgency, frequency, incontinence, there are quite a few options that are there. And perhaps compared to, say, 10 years ago when there were maybe very limited options, there are now quite a few. And we are now able to sort of provide a bespoke approach, sort of a custom-made approach for the person who has an overactive bladder, for that individual person's needs. And so it's sort of putting it all together and then having a plan, sort of like how the Dutch team played yesterday, where it was, where you have a quite effective strike. And it is sort of bespoke for every person. We start talking about fluids, and what we generally suggest, it depends on the individual, but we generally say is around 2 to 3 pints a day. We do advise about cutting down on tea, coffee, alcohol, fizzy drinks, even sort of citrus fruits, oranges, which we know can irritate the bladder and make those symptoms of urgency, frequency, incontinence worse. Exercise can help a long way. It was actually the therapists at Queen Square who told us about how they observed that patients who were undergoing sort of core stability exercises sometimes came back and said that their urgency and incontinence was better. And indeed, if you think about the core, if you think about the trunk, which is actually the core that you're trying to stabilize, the base of the core is the pelvic floor. So unless you have a strong foundation or a strong base, then only will you have the rest of the core stabilized. So you're actually using your pelvic floor, and perhaps that's some reason why, but that's just one example. Pelvic floor muscle contractions are quite helpful, not only for stress incontinence, but also for urgency. So say if you're sitting in this room and you find yourself suddenly desperate, needing to go to the toilet, if you squeeze your pelvic floor, you might be able to tide over the situation, allow the bladder to relax, and then maybe get up and go to the toilet. So exercises do help. When we talk about tablets, the first sort of line treatments are tablets that we call antimuscarinics or anticholinergics. Some of you might be on oxybutynin, some of you are on tolterodine, there's solifenacin. And to tell you the truth, between these medications, there isn't a big difference between them from an effect point of view. What we look at it is more from a side effect point of view. And in fact, you have medications such as, say, oxybutynin that we know are more likely to cause symptoms like a dry mouth or dry eyes or constipation. Whereas you have tablets like these, which where these side effects are less. And so we tend to prefer prescribing these sort of medications. Which tablet we use, of course, depends on the individual. So one person might have solifenacin, other person might have tolterodine. Now, this is one drug that we use more and more, especially in individuals who have cognitive trouble. So if there are problems with memory, for example, trospium and darafenacin are two medications that we use. And so there are quite a few antimuscarinics, and if one doesn't work, we tend to use another. Though they do belong to the same class of drugs, what we do know is that on an individual basis there are differences. And so we do give it a try with a second drug before we say it's time to move on to other treatments. And I've told you about the side effects that one might experience, and so that's why we always look out for other treatments, especially if the side effects become too much. And other treatments, the other treatment I'd like to maybe just briefly share with you is Botox. All of you have heard of Botox for many reasons, and believe it or not, it's effective for the bladder as well. And it's once again, the principle is that if you have an overactive, if you have a muscle that's overactive, you want to relax that muscle, and that's where Botox works. Be it for spasticity, be it for the wrinkles, be it for the bladder. So essentially, as I said earlier, it's an overactive bladder muscle that we call the detrusor muscle. So it's called detrusor overactivity. That's responsible for these overactive bladder symptoms of urgency, frequency, incontinence. And the Botox, so botulinum toxin is injected using what's called a cystoscope. Essentially, it's a camera that's put in, it's introduced into the bladder, as you can see. You have two types. So you have a flexible cystoscope like this, and this can be done under local anesthesia. So if someone were to have Botox with this, of course, a person comes in, have the procedure, and goes home the same day without the need for sort of general anesthesia. Whereas if it's a rigid cystoscope like this, there would be the need for general anesthesia. If you have it with this sort of camera, then you might be in overnight if it was required. And the Botox is injected in the muscle at various sites. This is sort of 30 sites that you have the Botox injected. Now, unlike injections for the skin, injections to the bladder are not painful. You do feel a bit of discomfort with all these instruments in, but actually, if you look at a discomfort score, if the lowest score is 0.5 and the top score is 9, on the average, individuals who had this in our department as part of a research study, they scored 3.4. So it's not really too bad. And unlike for, say, the wrinkles or for spasticity, where the effect is short-lived, maybe 3 or 4 months, the effects on the bladder are much longer, and it's as long as 9 to 13 months. So it is sort of a treatment that perhaps might be required only once or perhaps possibly twice a year. So it isn't certainly a first-line treatment, but for someone who has tried an antimuscarinic tablet, maybe number 1, number 2, might have tried something else, what's called desmopressin, and we find that these aren't working. This is the option that we would consider. This is actually a view within the bladder. You can see the blood vessels in the wall of the bladder. You can see the trocar going in. You can see that there's a bleb that's forming. That's the Botox going into the wall of the bladder. And the needle is moved. So that air bubble indicates that we're at the dome or the top of the bladder. And there's another site. So I told you 30 sites. So you've seen 2 of them being injected now. And you can see that bleb that would rise. This goes into the wall of the bladder. It does spread a bit in the bladder wall. Essentially, the effect of this is, it starts within sort of 10 to 14 days. And the effect, as I said, lasts for a long period of time. Now, because it relaxes the bladder muscle, what happens is it does sort of, there is this possibility that you'll start retaining urine. And if the post-void residue arises, then you would have to resort to self-catheterization or some sort of a catheter to empty the bladder. So individuals who do go down the route of Botox injections are taught self-catheterization. And the nurses spend time to teach, and we make sure that the person is comfortable with catheterization before we go down the route. It doesn't mean that everyone would require to use a catheter, but it's just in case, so that, say, 10 days later after the Botox, you find that there's difficulties in passing urine, there isn't a rude shock. Moving on to another treatment option that's available is using electrical stimuli to stimulate what's called the tibial nerve. So this is the nerve that runs here behind the ankle, at the side up the leg. And what's known is that it's been known for around 40 years that if you stimulate this nerve, it helps with these symptoms of urgency, frequency, incontinence. And there's been quite a bit of work in the last sort of 10 to 15 years. And it's now a treatment that's available in the UK. It's something that's, it has approvals from NICE. And it's a service that many units offer now. At Queensborough, we offer this unit. So what it involves is putting in this 34-gauge needle just behind the ankle, just above the ankle, and it's connected to a 9-volt battery source. And this generates a small current, which is measured in milliamperes, and the current strength can be adjusted, but it delivers this current at a fixed frequency. And for half an hour, this person would have this in, and after the half an hour, the needle is taken out and the person walks out the same way they walked in. And I've had it done myself by my nurses. It's not really that bad. There aren't many sort of contraindications to have this procedure. There are a couple, but most people we find that it's suitable. And what happens is the person has this treatment for half an hour, once a week, for 12 weeks. So it's a 12-week course. And after 12 weeks, we ask the person, have you benefited or not? We have questionnaires that we have to sort of try to objectify that response. And if they do say, yes, it is better, then they come back for what's called a top-up session. And this top-up is determined by the response. So the person says when the symptoms start wearing off, and afterwards they just ring up the department and they come back for a top-up. So this is something that we have found to be helpful in quite a few people with multiple sclerosis, and we have a few people who are coming back for regular top-ups. Moving on to containment. So if it is a problem of incontinence, there are quite a few containment products. I'll just share with you two such products. One is, of course, the Convene or the penile sheath that can be applied, and this is just to highlight there are various sizes and shapes. So it's once again finding a continence nurse who can spend time to take the person through the various types of convenes. And there are also various types of pads as well. So if one isn't suitable, there is another. And it's a question of persevering and finding which sort of containment product is required. Now, there are some individuals in whom having what's called an indwelling catheter, which is most appropriate. So an indwelling catheter would be unlike the catheters I showed you earlier, where you just introduce a catheter and take it out. That's intermittent catheterization. This is one that sort of remains within. The catheter can actually be introduced down below through the urethra, which is a natural opening, into the bladder, which is called a urethral catheter. Or it can be introduced through just below the belly button, called a suprapubic catheter. I've just kept this cartoon to emphasize the point that if the long-term plan is to have an indwelling catheter, that it should be a suprapubic catheter rather than urethral catheter. There are various types of bags so you have a leg bag or a bed bag that can be attached to the catheter that allows the urine to be stored. And these are themselves discrete. As you can see, there's a strap, and it's kept around the leg. And so it's not something that's evident when the person goes out. In some individuals, if they have a fairly large capacity bladder, a catheter valve is something that could be used. Just a word about urinary tract infections, and as you are aware, this may lead to worsening of MS symptoms. It can also sort of predispose to a relapse. If it is a question about recurrent urinary tract infections, we try to look for a cause. Sometimes the cause might be obvious. Perhaps it could be to do with the catheterization technique, for example, in which case the nurse spends time with the individual, and that's identified, that's worked upon. It might be that there could be, say, a stone sitting in the bladder, for example, something urological. It could be that the person is on, say, steroids or something else that may be suppressing the immunity. So if there is a cause, we try to identify it. In many individuals, sadly, we don't identify a cause, and there are people who are just prone for infections. It's just to do with the local environment in the bladder. Cranberries, there's quite a bit of debate about sort of cranberries, and you'll see one study that supports the use of cranberries, another study that doesn't support. What I tend to advise is to not to use a cranberry juice, but rather something that's a bit more concentrated, sort of cranberry extract tablet that you get from health shops. Some people find probiotic yogurts to be helpful, and then there's always a discussion about using preventive antibiotics. So to recap, the bladder is something that's often affected in people with MS. We want to always, as part of the assessment, we want to check and see if the bladder is emptying. There are quite a few treatments: fluids, exercise, pills, Botox, and tibial nerve stimulation or electrical stimulation. What's important is that if it is a problem, it is something that you should get in touch with. This is the Bowel and Bladder Foundation, the charities. At the primary care level, we have community continence teams. Hospitals speak to MS doctors and nurses. Now, we reside at the National, but if we do get a referral, we're more than happy to help talk about the issues of continence. Thank you.